Hey guys, welcome back to the basics of PFTs. Next, we're going to be talking about lung volumes. So this is just a picture of somebody breathing. So you breathe, 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 deep breath in, blow it out, breathe in, and keep breathing. So this regular breathing is called the tidal volume, and that's what you see here outlined in green. That's the tidal volume. It's just what you breathe when you're not thinking about it at all. All right, so the next thing you do is deep breath in, and that's when you get your inspiratory reserve volume. And this is kind of at the height of inhalation, so you have your tidal volume plus your inspiratory reserve volume, and that together forms your inspiratory capacity. So that's just me breaking it down into those three categories there. All right, so then what about blow it out? What volume is that? So that's basically something called the expiratory reserve volume. So that's when you're at your baseline volume and exhalation, and then you have to keep pushing past it and try to blow all the air out that you can. And then you take a deep breath back in, you get back to your baseline, and you're just breathing your tidal volume normally again. So then what is this FRC, the functional residual capacity that we always talk about? So that actually includes some air that you just cannot blow out, and that's below the ERV, and that is called the residual volume. And those two things together, the expiratory reserve volume plus the residual volume, is what is going to make up the FRC. So this graph is getting pretty complicated, but I just want to take a moment to point out to you guys what is the difference between a volume and a capacity. So if you can see so far, there's two main capacities here. One is the inspiratory capacity, and one is the functional residual capacity. The main difference between a volume and a capacity is that a capacity is made up of two or more volumes. And so if you see the inspiratory capacity is made up of the tidal volume plus inspiratory reserve volume, and then the FRC is made up of the ERV plus the RV. So that's what the difference is between a volume and a capacity, and that can be important for your exams. So with all that being said, what is the TLC? So essentially, it's going to be the entire capacity of the volumes, the total lung capacity, measuring from the very top of inhalation to the very bottom of exhalation, and including that residual volume, that air that you just can't ever get out. So why does this matter? Why do we care about all these lung volumes? So, the reason we care is because lung volumes can give us clues and insight into the underlying disease process that's going on with the patient. So for example, if your lungs are too small, then that would be indicative of a restrictive disease process. As mentioned before, like chest wall, obesity, fibrosis. If your lungs are too big, then that may be indicative of something like hyperinflation or air trapping, which we actually see with the patients with airflow limitation, like asthma and COPD. So which numbers mean what? So TLC, total lung capacity, if it's very reduced, then that means that you have a restrictive disease, something like fibrosis. And that's basically it for restrictive disease. For if TLC is elevated, then that is indicative of hyperinflation. And like I mentioned before, that can happen with airflow diseases such as asthma or COPD. And that's really all we look at with the TLC. The next number you might look at is the RV, that residual volume. Remember we said it's that air that you can't get out? So this is elevated in air trapping essentially, and that's something that you can see also in asthma or COPD. And just in case you guys didn't know, COPD is kind of like chronic bronchitis plus emphysema, and some people are more bronchitis, some people are more emphysema, but just know that all of those diseases can end up causing you hyperinflation and air trapping. So the last number that I want to tell you about with regards to the volumes is the ERV, the expiratory reserve volume. So this can be decreased, and usually when it's decreased, I think maybe this is obesity. The patient will be restrictive by a decreased TLC, so you'll already be suspicious of restriction, but then they have a normal CT chest and no real other symptoms of pulmonary disease, essentially. And so I always think, I wonder what their BMI is. So you check the BMI. If it's up and the ERV is down, then a likely cause of this is obesity. So in summary, number one, just be clear that you cannot diagnose restrictive lung disease on spirometry alone. You definitely need the full lung volumes as we've described here. Number two, just remember restrictive disease is defined by a decrease in the TLC, the total lung capacity. Number three, remember if you have actually an increased TLC, then that is suggestive of hyperinflation, which is related to disease like asthma and COPD. 4, if you have an increase in your residual volume, your RV, then that is indicative of air trapping. It's trapped air you can't get out. And lastly, if you have a decrease in your ERV, this suggests obesity. So check the patient's BMI, and that may be where their restrictive lung disease is coming from. So that's all I have for lung volumes. I hope you found that helpful and comprehensive. So please give me a shout out at mkgreer@emory.edu if you have any further questions. Thank you.